or were before that? Hello, we can start from this slide or before this? Hello? Hello?
Yes, sir.
So this is the last slide?
Yes, sir.
Okay. You should wait for some time or we can start. So we're talking about the chemotherapy, and so this is the mechanism of action. I think it's a chart from pharmacology. So how the manufacturer or the research people, they have designed this anti-cancer therapy is, look at this. For any end product of the basic need of our body is the production of the protein. Okay, how it occurs from purine and the pyrimidine. So in this process, so many chemotherapy drug, they will break this chain. So if this chain is broken, then we'll have this multiplication of this cancer cell checked. Okay, so they work in so many levels. So this is how this chemotherapeutic drug are designed, and you'll be asked about how they work. So you should know where they work. So now there is another thing is combined treatment, because if you diagnose something early, then we can treat it by this surgery, which is not possible all the way. So, but when some people come with advanced disease, then we have to combine all these modalities of treatment like chemotherapy, radiotherapy, or targeted medicine. So why? Because if we attack the enemy from all this front, then we'll have a better control of our enemy. So we'll use drug, they are active against the disease. We'll drug with a distinct mode of action and drug non-overlapping toxicity. So, you know, we have already mentioned that the cancer therapy is very notorious for this toxicity. So we should always be careful in choosing all these modalities of treatment. So what is the principle? Use effective agents. We use agents with a different mode of action. So we should be attacking the enemy from all the side. We use agents with a non-overlapping toxicity and consider spatial operations. We have already mentioned all this thing. So another thing is, new thing to you is the biological therapy. So chemotherapy, radiotherapy, and surgery, they are the traditional way of thinking. Now something has come up with the very big thing is the biological therapy. So they are very expensive. Look at this, $50,000 per quality adjusted life year. So this is very much expensive. And so what is that biology? There is something called targeted therapy, or you have heard that monoclonal or polyclonal antibodies. So biological therapy is use of body's immune system to fight cancer. So we all are prone to the cancer. Why? The most of us, we don't have cancer is because of this immune system. So why does these people with hepatitis, HIV, they have more cancer? Because their immune system is weak. So that's the simple reason. So same our strength which we have used in the cancer therapy, the use of our immune system. So what's there in our immune system? We have so many cytokines. So we can artificially make this cytokine, and we use this as the soldier to fight against the cancer cell. So biological therapy, there are so many variations now. Something called targeted therapy. So what is that? Every cell, they have receptors. So receptors is a different story, and we can have so many research on that. So make it very simple. So for all this growth of the temple cell, there is some stimulation. Suppose this is the cell. And in the cancer patient, there is some chemical that stimulate this cell. Then there is a proliferation of the cell. So what this targeted therapy does, they will put some chemical and they will just cover this target or receptors. Then the stimulation won't be there in this cell. Then ultimately this cell will die. So this is the very crude concept of targeted therapy. So angiogenesis means is a proliferation of the blood vessels. So for the survival of the cancer cell, you should have angiogenesis. If you look at this cancer cell, then they will just bleed the moment you touch it, because they need so much of energy, and they will derive energy from the blood vessel. So if you develop something that will inhibit the angiogenesis, they will stop angiogenesis, then they will die of starvation. So we have developed that thing. We block the angiogenesis. We'll do this tyrosine kinase inhibitor, means they are responsible for growth of the cell. So just to make the concept there, whatever required for the growth of the cancer cell, we'll develop that in the body and we'll put in the body, and that will check that growth. So two things, immunotherapy and the target therapy. So this in this picture is very nicely shown how does the immunotherapy work. The tumor cell bind to T cell to deactivate them. So this is the T cell and this is the tumor cell. So if you put this cell in this body and if you block this thing, then there won't be any multiplication. So what is the other way of doing? Immunotherapy drug can block the tumor cell from deactivating T cell. Okay, we'll have some drug that will block these two things here, or they can create a barrier. So immunotherapies, they help the immune system fight cancer by flagging cancer cells for the destruction. So they will come with the name of MAB, obinutuzumab, ofatumumab. Okay, they are the monoclonal or the polyclonal antibodies. And other is targeted therapy. They block distinct molecular pathway inside the cancer cell. So these are, they will block some distinct pathway, or they will increase the immune system of our body. And so T cell, B cell, they are the immune part of the immune system. So this is the very you must learn, and you should learn, because the next decade is the era of this target therapy and the immune therapy. So immune therapy, they come in the two forms, the polyclonal and the monoclonal. So as the name explains, mono means only one. They will target the only one site in the body, and polyclonal means they will target the multiple receptor in that tumor cell. So look at this. It's a monoclonal means, look at this receptor. They are similar shape. This one, this one, this one. So this antibody, you put antibody in the patient, and they go and check this by blocking the site. And polyclonal means they are all blocking everybody, every receptor. So this is how it works. So now another term. So our best desire and effort, our will is to treat the cancer, but that is not possible. So this is a dream till now. There are so many people in our country, they will come at terminal stage, and they will reach the stage where you cannot do many things. You cannot cure. You can do many things, but we cannot cure this patient. So what is this palliative care? The role is here, the palliative care means the aim of one of the aim is not only to cure the disease, but to give the patient a dignified life. So what does that mean? Means he should live his remaining life with dignity. Means you shouldn't be pain. You should be able to do the daily activities, and when that stage is reached, then we should be giving him a decent life. However, there is the distinction between the palliative and the curative treatment is not always clear, because there is not in a black and white that the stage, the people at this stage are cured or people in that stage is not clear. It depends upon the place where you stay, the place where you work, so many things, the team which you have. So these all are there are so many gray area there. So 20 years ago, the cancer was perceived as a disease that was either cure or it is not. Okay. But now there is development of this palliative science. So it's not only cure or not, but even if we cannot cure, then we have to give a decent life to the patient. So before there is something called 5-year survival. So maybe 20 years back, now treatment of cancer was judged on the basis of whether the patient can survive 5 years or not. So that is not the realistic right now. Now the cancer patient, they deserve a very good life. The patient will live with their cancer perhaps for years. Okay, like in prostate cancer, the patient can live for so many years, like in breast cancer also. They will live with the cancer. So this is another very good sentence. They will die with cancer, but not necessarily of cancer, because in the older patient, now maybe life expectancy of the Nepal is more than 70 now. Okay, even if you don't have cancer, the average Nepalese people will die at 70. But even if you have some cancer, then we have some treatment, then he can survive for 70 years, and maybe he can die because of heart attack or because of any other cardiac problem or any lungs problem. So it can happen. It has happened. Control and relief of the symptoms is crucial to the successful management of the patient. So symptoms, they should be symptom free. So that is our main aim when we cannot cure the patient. The much of the fear associated with the cancer is due to the past failure to control the patient's symptoms. So why it was that much fear is because of the symptoms. So patient fear the symptoms, distress and disruption. So palliative treatment has goal of its is the relief of the symptoms, and the most notorious thing is the control of the pain. So patient has the pain at the terminal stage, and our aim is to relieve that pain. So there's this chart of the palliative or the supportive care. There are so many headings and subheadings. Relieve the symptoms. Not only the drug, there are other things that come into play now. The psychosocial intervention, physical and practical support, information and the knowledge, nutritional, social, financial, spiritual. So many things come here now, because only the drugs, we cannot cure the patient, right? So because the chronic illness, they are psychologically exhausted, and here comes the role of spiritual support. Okay, so many people, like somebody in our country, so many babas and matas, or what they are doing is they are taking benefit of this thing, because in the cancer treatment, the people will definitely come in one stage where you don't have any support from anywhere. So at that stage, they will seek this support now. So other thing is the end of the life. The palliative and the end of the life is a distinct thing. The palliative care means the patient can do their normal activities in palliative phases, but end of the life means the patient is the bedridden. Okay, now they require the support from the expert people for their day-to-day life. And at this stage, now there is the concept of something called good death. Okay, so this is a very good thing, or dignified death. So how we can give that? It requires a lot of discussion. So there is appropriateness of the active intervention at that time, like patient should we keep it in ventilator or not? Somebody is in terminal stage, should we ventilate them or not? So that is something for discussion, because which you can save few hours or few days. Should we be doing that? So euthanasia is a very controversial thing. So it is not legalized in our thing. The first thing is you know euthanasia or not. That means the mercy killing means can we give some drug to end the suffering of the people? So there is a matter of discussion. The physician assisted suicide, living wills, bereavement, spirituality, support to allow death at home, and problem of medicalization of the death. So these all are the very nice and the thing for the discussion there. So we have come to the end of this topic. It's very interesting and very useful for the new generation, and you can do a lot of things in this neoplasm. Okay, so that's it. Any questions, any queries? Hello, you are there?